Talk about the anatomy of rotator cuff, recent advances and their clinical implications. We know as surgeons, our work is to restore anatomy. With respect to the rotator cuff, both osseous and soft tissue anatomy is important. And I'm going to touch over points on the coracoacromial arch, something about the bursae, the rotator cuff footprint, and the neurovascular structures around the rotator cuff. The purpose of this talk is to elucidate recent advances and how it influences our decision making in management of rotator cuff tears. So I'm going to start with the coracoacromial arch, which we know consists of the coracoid, the acromion, and the bridging CA ligament. So we'll start with the morphology of the acromion. We all know that Mihir introduced the concept of subacromial impingement, and hence the concept of acromioplasty started. Bigliani described three types of acromion: the flat, the curved, and the hooked. And accordingly, we know that the hooked type has the highest incidence of bursal surface or full thickness rotator cuff tears. The recent advance is a type 4 convex acromion, which usually doesn't have much significance with respect to rotator cuff pathologies. But the keeled acromion, recently described by Snyder and group, has a very high incidence of bursal and full thickness rotator cuff tear. It basically consists of an undersurface keel or spur extending from the anterior to the posterior limit of the acromion midway. Very high incidence of full thickness rotator cuff tears, and hence it has been described that an acromioplasty should be done even prophylactically when this keel type of acromion is detected. You get everything in literature. As much literature is available about the concept of subacromial decompression, there is enough controversy whether it actually helps. Zuckerman and Chang in their cadaveric studies have found nothing what Mihir and Bigliani described. And hence, as of today, the concept is of limited acromioplasty with whatever kind of procedure they are doing. Why limited acromioplasty? Because Green in his study has very clearly mentioned that more than about 4 mm of resection on the undersurface of acromion leads to loss of about 50% of the deltoid origin. And the deltoid, we know, is the most important structure in any shoulder surgery. Anything more than that causes a release of almost up to 70 to 75% of the deltoid origin. Hence, the latest concept is only of a limited acromioplasty, be whether you're doing an open or an arthroscopy procedure. Os acromial, we know that the acromion arises from three centers: the pre, the meso, and the metaacromion. And failure of fusion in between any leads to os acromial, which can be two types. The type 1, which is a smaller one, where is failure of fusion between the pre and the meso, and the bigger one, where is failure of fusion between the meso and the meta. 8% incidence, and it is bilateral in about 30% of patients. In normal circumstances, an asymptomatic os acromial can be left by itself. The problem occurs when an os acromial is associated with a rotator cuff tear. So the latest consensus is an asymptomatic os with a rotator cuff tear, you manage the patient as if the acromion is normal. But if the patient is symptomatic, number one, we need to decide whether the os is symptomatic, which you can do by MR studies, by seeing for edema signals either in the AC joint or in the os. And if it is symptomatic, then we have to be sure that we need to resect the type 1, either open or arthroscopic, and fix rigidly the type 2, either by wires or screws. If the os is asymptomatic and is associated with a rotator cuff tear, the treatment is exactly what you do with a normal acromion, but we need to avoid an acromioplasty because we would otherwise destabilize a stable os acromial. Coming to the CA ligament, we know that the CA ligament extends from the coracoid to the acromion. It consists of two bands, the anterolateral and the posteromedial band, and the anterolateral band is one which is the culprit causing most of the impingement. We need to identify the anterolateral band in most of our surgeries, because if we limit our acromioplasty to only the PM band, our acromioplasty will be incomplete. We also know that the CA ligament thickens with age and leads to rotator cuff degeneration. The coracoid, I'm not going to talk about the normal anatomy of the coracoid, but I'm going to straight hit the concept of subcoracoid impingement. Subcoracoid impingement, like subacromial impingement, is impingement between the lesser tuberosity and the coracoid, which occurs in flexion, internal rotation, and adduction. This subcoracoid impingement can lead to injuries or tears of the supraspinatus, subscap, injuries to the rotator interval, and even thickening of the CA ligament. Schulz has described two types of coracoids, type 1, type 2, depending upon a true AP X-ray. A type 1 coracoid is one which overlaps the inferior part of the glenoid, and this type 1 coracoid causes subscapularis tears. And type 2 coracoid overlaps the superior half of the glenoid on X-ray and is responsible for supraspinatus tears. The concept of coracohumeral distance is again important. Any distance which is 10 mm or more is not significantly associated with subscapularis tear. But when the coracohumeral distance is less, 5 mm, we need to include a coracoplasty whenever we are treating any kind of rotator cuff pathology. Coming to bursae, three bursae we know: subacromial, subdeltoid, and the subcoracoid bursae. The subacromial is between the acromion and the rotator cuff tendons. The subdeltoid is between the fibers of the deltoid and the humerus shaft. and the subcoracoid is between the subscapularis and the conjoint tendon. The significance of these bursae is they have very high level of cytokines, and hence they cause pain and inflammation when there is associated with rotator cuff tears, and hence we have to take care that we do a thorough subacromial decompression. Again, the anterolateral corner of the acromion is the center of the bursa and not the center of acromion. We need to know the limit of the subacromial bursa, which is about 2 centimeters anterior to the anterolateral corner of the acromion. Laterally, it extends up to 4 centimeters lateral to the lateral acromion. Posteriorly, it's only midway between the anterior posterior border of the acromion, and medially up to the AC joint. Very important, the rotator cuff footprint. Till now, we were in the concept that the rotator cuff has a linear or point insertion. But we now know from anatomical studies and even arthroscopically that rotator cuff, besides having a linear point of insertion, also has a medial to lateral footprint, which we called the rotator cuff footprint. Correct repair of the tendon according to this anatomical footprint is very important. In fact, the anterior posterior extent is almost 40 millimeters, and the medial to lateral extent ranges from 12 to 14 millimeters. This is an electroscanogram which clearly shows a footprint kind of insertion of the rotator cuff in the gyratory tuberosity. Curtis in his study has defined these footprints. You can see the supraspinatus has a footprint of almost 1.5 centimeters square. Bigger than that is the infraspinatus, which almost has a 1.76 centimeter square of footprint. And similarly, subscapularis has the biggest footprint size. And when we do our rotator cuff tear repairs, we need to cover this footprint. And that is why the concept of double row or transosseous equivalent type of rotator cuff repairs has come into existence. Again, landmarks, whether we do open or arthroscopic, the anterior edge of the GT is a very important landmark when you're operating. 12 to 13 millimeters behind the anterior edge is the insertion of the supraspinatus. About 9 to 10 millimeters from there is the insertion of the infra and the supra. And 12 millimeters posterior from that point is the insertion of the teres. Arthroscopically, when you are inside the joint or above, if you want to identify the junction between the supra and the infraspinatus, the anterior limit of the bare area is described as the junction between the supra and the infraspinatus. And you can see that the infraspinatus doesn't insert in the edge of the cartilage as the supraspinatus does. Hence, when you're repairing your infraspinatus, your suture anchors cannot be at the edge of the anchor, but should be beyond the bare area. With respect to the axillary nerve, this is the famous diagram of Hoppenfield, which says 5 centimeters from the lateral edge is the axillary nerve. But Settig in his study has described a safe area. He's made a quadrangular, which is dropped. The posterior lateral corner, you come down about 6 centimeters, and from the anterolateral come down to 4.9 centimeter. This quadrilateral space is a safe space, and it is not 5 centimeters as a dictum. This anterior and posterior limb depends on the arm length, and there is a ratio or index with which you can calculate the anterior posterior limb to decide your safe area when you're doing a mini open or open rotator cuff surgeries. So to conclude, we as surgeons, we need to deliver, so we need to understand anatomy to avoid any arthritic injury, and controversies around the treatment of rotator cuff disease is what you're going to face in the next few talks. Thank you.